Thank you, Priya, for those kind words and for having me in this course year after year. I think this has been one of the learning experience for me as I graduate myself from still a novice surgeon. I would always call. I learned so many things from you. So I'll be talking of the anterior vitrectomy and IOL capture. Can I? Yes. So IOL capture is one which was discussed way back in 2003 by Dr. Kimball when he said that capturing the intraocular lens through the capsulorhexis opening, which is at least 1 to 2 millimeters smaller than the optical is required, and long-term centration of the IOL prevents uh, the vitreous from coming into the anterior chamber. That's what it helps as a scaffold if you have a PC rupture. And this is another study which has actually said the optic capture affects refractive outcome with a very low myopic shift as compared to had it been in the bag itself. So this is in no way you can always consider it in the bag, especially in the high myopes and all, if it goes down. So optic capture, you can see this is the various way the lens, the haptic goes into the sulcus and the optic goes into the back, and you end up in a spindle shape this way. And there are various other ways of doing posterior capsular rhexis. You go behind the posterior capsule, or both the rhexis, haptic and sulcus go. So we'll be talking about anterior capsular rhexis in this series of cases. And this is, I go with a small around 7-minute video. Now look at this. Anterior vitrectomy and IOL capture. Look at these cases. This is the first case. As you can see, this is quite a hard cataract. And as I'm going through with the central trench, and then I'm separating the nuclear. I don't know at what point of time I even could not make out, but then it's somewhere when I'm doing the left hand, moving those nuclear pieces to the west. That is where I might have ruptured somewhere. The zonules must have given off, or the bag must have. That is where I saw that there is a big chunk there, and almost all of the lens nucleus is there. So I put in viscoelastic there, high molecular visco, in this case visco. I have no financial interest, but that works the best way to tampen it. Once I get it, this was a 5mm rhexis, so I just rotated it and got it out in the anterior chamber. And I had almost, eaten up a little bit by that time. But then again, I went ahead with because I put some plug behind those nuclear material and reduce the bulk of the nucleus. And it's very important that I put a lot of viscoelastic, which protects my endothelium as I'm doing the rest of the phaco almost in the anterior chamber. Once I've done that, I have reduced the bulk of the nucleus. I find out that place, and I put, in this case, a multi-piece IOL. It goes first right over the iris, because the pupil was small and I didn't know whether it will go directly in the bag in this stage. So I put it in the over the iris, and that is the classical way everybody can do it. And then carry on with phacoemulsification again under the cover of high molecular viscoelastic. This is very important. And once you're there, then you actually take a stock of the situation. You might have some nuclear or cortical matter stuck there. You can go into the vitrector. This is what I'm doing, going ahead with the vitrector, the small nuclear pieces with that. I can eat it off, and then gradually, this is I got enough space, put a viscoelastic, and this I take it on the sulcus, rotate it, and other haptic again I rotate it. So this is very important. On what plane I work at, I should work it at just below the iris, and this is where very important how you push it. And once that is done, I do my tapping of the nucleus and the optic of the lens. And once I've done that, I check it whether it's the optic has gone behind the rhexis margin, and in small people it becomes difficult, but one has to be very careful whether if you want to do it so it goes right behind. And then I finish it up with the routine triamcinolone test. I see there is no much of a vitreous, and whatever is there I can remove it. And once it goes there, and the triamcinolone also helps in reducing the inflammation. And this is another case where I'm going into the last pieces, and when I'm going to the last pieces, I'm left with a little bit of epinucleus, and on that's the time when I see that there is a opening there, and there I'm trying to take it, and the infusion is on, and there I go there, it is the epinucleus, and there I see a big opening there, big PC rupture. Once I have that, and now I know that I have to remove the remnant part, and there I go with my In this case, as the pupil is dilated, I go with my scaffold right into the sulcus instead of waiting for putting in the iris. See, there I have noticed it. I've got the space there. I've got that potential space that the leading haptic goes into the sulcus. The trailing haptic, again, I just keep it over the iris, and there it is. I just keep it over the iris, rotate it, and take it there over the iris. Once that is done, well, there, and see a lot of cortical matter that comes out. I go with my vitractor, clean up that. There, once I've done with that, there use a alternate vitractor and IA. That means almost all machine you can do, and here I can use the cut IA with lower cut rates, because you are removing the cortex, and then follow it up with, once I've cleared the vitreous, and I follow it by IA mode, and there I have got, and then once I get it there, yes, I'm removing the part of the cortex there, and then I just tap it and get it over the below the rhexis margin, and then the customary check with the triamcinolone, and there I can see yes, a lot of vitreous is still there, and then I continue with my vitrectomy, whatever is going on. So this is how it helps that anterior, the lens with the optic capture has helped it to keep it within the vitreous back, and the vitreous doesn't, in the post-op period, if there is a sudden exertion and all, the vitreous will not come out in the anterior chamber. So it's very important you get a right size of rhexis. In the case if you have a rhexis around 6 millimeter, then that would be a problem. The lens would still pop out. So, and it becomes difficult with the multi-piece lens. And this is again on my case, I just show how we are doing the capture there. You can see I'm carrying on with that by manual IA, and at that place somewhere down the line, either I left the infusion off, there I can see the rupture there, and this is how I go in with it. You can see I've got a potential space made, put in viscoelastic, and the lens goes in slowly there. I just get it. It's good that you can support it by the left hand at this stage, but however, the lens is again rotated, taken into the sulcus, and there it's there you can just tap it one to the left side and right side, so you get that spindle shaped anterior rhexis margin there securely placed. And in this case I was sure there is no vitreous, because I had just tamponated the vitreous with the high monocular viscoelastic. And again there will be case, I think Partha would be showing next that
Ajay, can you just stop for a second? There is one band coming of the time. We are not able to see a video. I don't know whether it's for me only or for all of you. One broad band right across the IOL with the timer showing. The room call.
No, I request you to change the view of Zoom. So on the screen itself, on the right hand side, top bottom, you will see view over there, and then you can make it as a speaker or maybe as a gallery.
Oh, okay.
Okay.
Sorry.
Yeah, no problem.
Yeah. I just continue it.
Sorry.
So this is a case where there is you can see a horizontal tear there. Now look at it. The margin of the tear is not exactly in the center, a bit off center. So my question was whether I can put the lens in the bag or not in the bag. Now I put a lens in the sulcus. The reason I'll just show you, there's a similar case. You can see there is an upward margin of this. And see the similar case when there is a rupture, I put in the lens and see the visco goes right behind it. So I'm sure there is no vitreous here at this stage. So in this case, see, I put a high molecular viscoelastic, so plug that hole. And again, I go to the periphery, the fornices, again, rightly. And here I put a single piece IOL. Now the single piece IOL, this happened to be a toric IOL. So I could even put the toric IOL slowly. And this particular lens is so soft on the bag, the way it opens up. And this was done almost 7 or 8 years back. And I'm still follow this patient yearly. And see, in this case, since the margin was up-rolled, and there was no, I could have put a single piece also, but then that would have been a risk. And so in this case, again, as I said, I put a plug of the high molecular viscoelastic, and then the same way I take out the space there behind the iris, and then the lens goes slowly. So it's very important that you see the trailing, the bleeding, are you getting in the right place? And once that goes in there, see slowly again, roll it, see that and see at that point again, go in there, right. It's very important. This step is very important because there, but lock it, lock the other side. And once this is locked, this would stay forever that way. I think I showed you some picture in the beginning how the spindle shape, and that is the break there. And you can just, in this case, thank you for your patient hearing. Thank you.